Okay, welcome everybody to this month's Power Player interview. I am so honored. Liz Bayley is joining us. I have been a big fan of your work for a long time, um, looking at everything and studying everything. So I'm always very honored to have people that, I can learn from and that our audience can learn from. So we're just going to jump right into it and just introduce yourselves to everyone on the call and kind of how you got obsessed with the foot, kind of as I am.
hmm Yeah. Well, first of all, thank you very much for having me. And it's lovely to meet you in person. I feel like we know each other even though
Yeah.
we've never met. Yeah. So a bit about me. So I'm a dance specialist physiotherapist and I work in London in the UK. And it's because of my specialism in dance as to why I got specialized in foot and ankle, because dancers injure their feet all the time. So depending on the dance style that you work with, it varies. But classical styles like ballet, probably the most prevalent for foot and ankle injuries, like over 60% of the injuries you see will be foot and ankle. Irish dancing is right up there as well, probably possibly higher than ballet. Whereas something like street or hip hop is much lower, foot and ankle for obvious reasons.
Mhm.
Like contemporary dance, they dance in bare feet, so often they have very high
Mhm.
foot and ankle injuries. But either way, I just saw so much foot and ankle when I first qualified as a physio. I thought I need to get better at this fast. So I never decided to specialize in foot and ankle, but I just did. I just the more you see it, the
Yeah.
better you get at it. And then I started to teach a little bit here and there, which again made me better at my job. I saw more complex cases, and I love it now because I love specializing in something because you get to see the really interesting complex cases on top of the more day-to-day stuff.
Yeah.
So in dances, I'll work with the whole body. So I've been physiotherapist in the West End in London and been on most shows that are in the West End. So either the shows or the theatres. But I was on Wicked for 3 years. I was on Lion King for 3 years. And those shows, obviously, they have big costumes, big puppets. So that I used to treat necks, shoulders, wrists, everything. And I still see lots of other injuries in dancers, not just the foot and ankle, but I'll see second and third opinions in professional athletes and also the average everyday person. And I'll see more chronic and degenerative cases as well as foot and ankle. So I still see quite a big variety of injuries, but
Yeah.
yeah, it just depends on the people that come to my clinic is in the West End of London, right in Theatreland. I also work at a dance and music college in Greenwich in London, and right now I'm the physio on Matilda the musical, which is
Oh, nice.
one from my clinic. But I'm just there one day a week, so and I'm at my clinic 2 or 3 days a week, so I stay busy. And then on top of
You're
that,
busy.
I'm busy. Yeah, and then I do teaching, international teaching on top of that. So I was in the States earlier this year and all around Europe and Copenhagen earlier and lots of other international teaching, which is very challenging, but teaches me a lot.
Yeah, I think the teaching keeps you on your toes.
That's why I do it.
Yeah.
Yeah, because you have to be accountable. You have to know you have to be up to date. You have to know the answers to difficult questions. And if I didn't have to present in front of 50 to 100 people, I just wouldn't work as hard as I do. It
Yeah.
keeps me accountable.
Did you like working on the sets of Wicked and The Lion King? I think that would be fun.
Yeah, it is fun. Like whenever people see, I finished on The Lion King about this time last year, actually, and I put this video out of my 3 years there, and everyone was like, "That's the best job in the world,"
Yeah.
and it is. But the reason it is just it's the people, just people that work in musical theatre, the singers, the actors, the whole cast, the crew. They're such an amazing bunch of people to
Yeah.
work with. They've got this energy for life, and it feels like a family. Lion King in particular,
Yeah.
there's a real family feel to that. Yeah, it's wonderful. I just adore working with performers for that reason.
I don't think people realize how intense that is too. I mean, there's a lot of shows, there's a lot of, a lot of time that goes into that. It's this, I mean, those athletes, I mean, there's a lot of reps that they're putting on their feet.
Yes, oh, I'm not going to remember the numbers now, but they compared professional ballet dancers with basketball players.
Yeah.
And I can't remember the numbers of jumps, but dancers will do 2 to 250 jumps in a class, which is, I think it's above what basketball players do, but also it's much more concentrated towards the end of like a class. Now that's a dance class, but if you look at like a show like Lion King, it's
Yeah.
known as being one of the most athletic shows in London, and we were actually the first West End show to have a full-time physio. So all the shows have access to physiotherapy, but I was the first in-house physio, which is quite a big deal. You think
Yeah,
like
yeah,
the Royal Ballet is down the road from Lion King, and obviously they have a state-of-the-art physiotherapy and health medical department, absolutely second to none. But the facilities that ballet dancers have had for quite a long time, we're still a long way from getting that in the West End. So, I know that you were a dancer, so you'll be
yes,
familiar with this. And I was a professional dancer too. That's how I got into being a dance physio. And back when I was dancing, so that was 20 years ago, we didn't have a lot of education or knowledge around injuries, prevention,
yeah,
certainly not S&C. So I think now that's really changing, and the kids that are studying now get lots of education around injury prevention, nutrition, sleep, recovery, all of that. Because I help teach some of those modules at Trinity
yes,
Lab where I work, so I hope that that's going to really bring a change to the culture and empower dancers a little bit.
yeah, and it's needed. I think across the board with like all different sports too. I mean, even, you know, with the running population, it was just we're just running and we're just running, and there was never the conversation of strength training or load training and things like that. And now, I think we're starting to realize how important all of that is.
Mhm.
Speaking of load, one of my I love watching your Instagram account, and there's several comments that always make me laugh on there, and they're always talking about loading it. Um, and how important that is for the foot and ankle. So let's get into. I kind of wanted to talk to you today. There's so many things we could talk to about foot and ankle. So you and I had discussed kind of diving deeper into medial ankle pathologies and kind of, you know, teasing some of these out. And there were kind of three that I wanted to get your thoughts on. And the first, I love all of your posts on FHL work,
Mhm.
flexor hallucis longus, and how it can often be kind of misdiagnosed or missed as an Achilles tendinopathy. So let's kind of start there because I know that is something you treat or you seem to treat often.
Yeah, definitely. It's probably the first thing I think of when a dancer comes in with posterior ankle pain or even medial ankle pain too, because it can be mistaken for tibialis posterior tendinopathy.
Yeah.
That's a big one. And Achilles tendinopathy, obviously, because that's the most common thing people think of when pain in that location. So the reason that dancers get a lot of FHL tendinopathy is because they have to point their feet thousands of times a day. And if you look at when dancers are trained in order to get that, I know you're obviously well aware of this, having been a ballet dancer, but when they point their feet, they want to get the most beautiful line they can, and that often includes really using the toes to get that plantar flexion through the whole foot. And what it often results in is that dancers can overuse their longer toe flexors quite a lot when they're pointing, but also when they're jumping and landing. And the reason we know this is probably true is because there was a study done in like 2015 where they tested dancers versus non-dancers on a modified heel raise test.
Hmm.
So a modified heel raise test is when the toes are off the end of a block. So they're not on a flat surface, their toes are off the edge of the step. So they can't use their toes to push up. And what they found was that actually dancers could do less than
Yeah.
non-dancers. Yeah. So I think the numbers were the non-dancer group were able to do about 28 repetitions and the dancers could do about 22. So when you think about how often dancers are rising and come back into neutral, they should have really strong calves and really strong heel raises. But as soon as you take the long toe flexors out of the picture, they seem to have a drop in their performance. That was with this particular group,
Yeah.
obviously. Yeah, so it's quite a small study. It hasn't been studied extensively, but I thought that was an interesting
Yeah.
finding because if you ever work with dancers, you'll see this a lot. You'll see FHL, so flexor hallucis longus tendinopathy. Mostly, you can get flexor digitorum longus, but it's far rarer. I've never really seen it, I suppose. Something about that big toe. So when that becomes overused because of this constant pointing and flexing, and also they're going into deep dorsiflexion when they land their jumps or going into plies and then
Hmm.
pushing back out into full. So it's a full range of motion from the tip of the toe through the ankle into the calf. And that causes this overuse injury, which is often more of a tenosynovitis, actually. It doesn't have to be a tendinopathy. So it can be just irritation to the sheath. And that's from the repetition of going through those ranges rather than true excessive loading. But it can often be a bit of both. They're both under the umbrella of tendinopathy. But what it presents as is pain in the posterior medial ankle, usually. Now, we know that the FHL it's the most posterior of the tendons behind the medial malleolus. So you've got your tibialis posterior, flexor digitorum longus, flexor hallucis longus. So that's the closest to the Achilles tendon. So it can often masquerade as Achilles tendon pain because it's in the same kind of area. But the difference with this is it often can wrap around the malleolus and it can certainly travel into the arch of the foot, and it can also present underneath the big toe, like between the sesamoids.
Yeah.
So the whole track of the muscle can become sore, but it's most common behind the ankle where the tunnel is, that interosseous tunnel where the flexor tendon goes through it. And that's because it gets irritated in that tunnel. So the way to be aware, and of course, it's not just dancers. So dancers primarily, it's called dancers tendinitis, but runners can get it for sure. Any sport where there's propulsion or like sprinters and things like that. So it's something to really be aware of. The reason is because the treatment does change a bit. So it does change the management. And the way it changes is that you really have to address the foot more than the ankle. Whereas with Achilles tendinopathy, you'd be thinking more about the ankle and the calf. Now, you and I, if we had an Achilles tendinopathy, we would rehab the foot like crazy because that's our bias. We do
Yeah.
that with everybody, right? So, but before, like when I was a sports therapist, say 12 years ago, I wouldn't have thought of the foot for an Achilles tendinopathy. I would have just thought calf.
Yeah.
And most physios are the same, most, not all. And it's not wrong, but I just think you can get better outcomes with Achilles, any sort of foot and ankle issue with foot strengthening. Now, you and I are absolutely on the same page with this, so I know I don't need to argue that to you. So for me, actually, I'd probably rehab them quite similarly. But if you don't include foot strength and big toe strength with FHL tendinopathy, it won't get better, And
Yeah.
we know that if you train the calf, you are also training the foot. But in the same way as you can target the quadriceps of the leg by doing, say, knee extensions, you can also
Mhm.
target the foot intrinsics by doing certain types of exercises. And while the foot will become stronger if you just do calf raises, when you get longer tendon issues in the toes, if you can try to bias the exercises towards the intrinsic muscles, which support those muscles, it does seem to have better outcomes. And now I've got no research to show that. There's no
Yeah.
RCTs been done that I know about. But when I work with it all the time, it seems really important. And it makes sense anatomically, and
Yeah.
physiologically. So with an FHL tendinopathy, you need to be working FHB, so flexor hallucis brevis, abductor hallucis, adductor hallucis, all of the intrinsics, so the quadratus plantae, the lumbricals, and the calf. And it's nice if you can try to work the calf in isolation from the long toe flexors. The way to do that might actually be a modified calf raise, where you don't let the dancer use their toes off the edge of a block. So that's where the rehab would change differently from something like an Achilles tendinopathy. There was a study done about this modified calf raise, and actually, annoyingly, it showed that when they did an EMG study, but this was the same group that tested it previously in 2015. They did an EMG study and they tested to see whether a modified calf raise toes off a step would offload the longer toe flexors and place the load onto the triceps surae. And what they found was that in healthy people, it did. So the FHL wasn't activated. But in some of the pathological FHL patients, it actually increased the load through the FHL tendon. Now, that's a very specific small study, and I don't think it's been followed up, or if they have, they haven't published it yet. But so there's some evidence to show that actually training the foot that way in a pathological population, which is what we're talking about, might be counterproductive. So what I do
Yeah.
is I try it with the person, and if it doesn't increase their symptoms and their big toe doesn't continually hook over the edge of the step, because if it is, it means their FHL is going.
Yeah.
If they're able to maintain a flat foot and a good calf raise and it doesn't reproduce their pain, then I use that as early rehab for FHL tendinopathy, a modified calf raise. If it reproduces their pain or their toes are still clawing over the edge of the step, then I don't use it. So it just depends.
Yeah.
But the way to tell if it's an FHL is to test the big toe, because if it's an Achilles or a tibialis posterior tendinopathy, then range of motion through the big toe and resisted movement through the big toe won't be painful generally. So I test the big toe in three different positions. So I do it in neutral, so the foot in neutral, and get them to push their big toe against my fingers. Often that will give them pain in the back of the ankle. Done. That can be diagnosed pretty much as an FHL issue. If you then stretch it all the way back, often the tension through that will give them pain through the back of the ankle. And you can palpate it too. So you can hook your fingers around the medial part of the ankle and feel if there's crepitus in there. So that if the tendon has adhesions, you can feel a bit of feels like creaking through the tendon. And often the person will say that the back of the ankle is creaking when they point and flex their toes. They will often say it's textbook. I've had a number of people come in and say, the back of my ankle hurts and it creaks when I point and flex my big toe. And I'm like, I know exactly what it is.
Yeah.
Easy diagnosis. Of course, you can get crepitus in the Achilles tendon paratendon, the sheath of
Yep.
the Achilles. So you can get that in the Achilles, but it's in a different location. If you're very specific with your palpation, you can differentiate whether that's the tendon or deeper into the back of the ankle for the FHL. I also test the FHL by getting the person to curl the big toe around my fingers and then pull against it, hook against it. And often, if they can't even curl their big toe, it's a really good sign that there's some kind of tenosynovitis in the sheath, because it stops them from being able to isolate it. That's something I've seen clinically time and time again. So if the person can't curl their big toe around your fingers and they've got symptoms that sound like it's FHL, it almost certainly is. It's a good test for it. And then I
So
also
they
test.
won't be able to isolate. They won't be able to curl it. Yeah.
Yeah, and it's because, like if you get tenosynovitis in the hand tendons, people get triggers. Like
Yes.
it slows down the movement. Just the thickness of that synovial fluid in the sheath means they're not able to use it as efficiently. I've seen it many times. It always matches. Really interesting finding. And then I just test it in plantar flexion as well. So foot pointed and then pull the big toe up against, and that biases the intrinsics a bit. So I test the big toe in three different positions. I feel around the back of the ankle. And all of that put together, plus tests for the Achilles and the tib post, which would be your usual. So, your calf rate, obviously calf raises are going to be painful if it's FHL as well, but it's more the palpation, I suppose. So palpate the Achilles tendon, take them into dorsiflexion, repalpate it. Is it less painful? That's called the London Hospital test. So that shows that the tendon fibers are slightly stretched, which is more difficult for you to penetrate them, which shows they might be part of the pain driver. So if the London Hospital test is negative, go hunting somewhere else. And then for tibialis posterior, obviously you're palpating around the navicular tuberosity and underneath the arch of the foot and doing resisted inversion and things like that. But with specific palpation, good anatomical knowledge. So if you know what you're looking for, because the foot is so superficial, you can be specific with
Yeah.
palpation. Yeah, I always say that. Like I'm the first to say in the back, I'm not sure if I'm on a facet joint or
Right.
or a paraspinal muscle. I mean, you're on both. It's very hard to identify certain structures in other parts of the body, but in the foot and ankle, you definitely can. So if you know your anatomy, it makes diagnosis easier. At least you know what you're
Yeah.
looking at.
I know I've seen you do an assessment too, with like a needle wall, and then
Oh
you'll
yeah,
have the big toe. Can you go through that one?
thank you. I'd forgotten that one. Yeah. So I call it the knee to wall FHL test. It's called like a knee to wall excursion. It's called an FHL excursion test, or yeah, FHL excursion test. So there is actually a device that was made, and it was in a paper by Mitchelson in 2020, and they had it. You basically had this thing where you measured a knee to wall, and then they put blocks of different heights underneath the hallux. So to lift it to say 20 degrees, 30 degrees, 45 degrees, and they retested that knee to wall measurement, so the ankle dorsiflexion. And what the paper says, is that ankle dorsiflexion reduces as hallux extension increases in almost everybody. And if you test it, that's true. Like it's always a bit harder to get the knee to the wall. But if the FHL isn't pathological, they can still do it. They just have to push harder when I see it in patients. What they were looking for in the study was whether a restriction in that ankle range of motion matched a positive FHL stretch test. So what they're talking about there is if you just take the foot into dorsiflexion to neutral, and you just support underneath the first metatarsal and just take the hallux into extension without too much pressure. And if it's less, this is just open chain, not closed chain. If there's less than 20 degrees of excursion in the hallux, they defined that as having a tight FHL. That was what was causing that loss of movement. So what they were looking at was if people with tight FHLs also had a reduced knee to wall on this machine where they measured FHL excursion. And what they found was there wasn't a significant difference between people with tight FHLs and normal FHLs. So they said they felt the test wasn't clinically significant. There was a difference, but it was only about 2 degrees or something, and it wasn't statistically significant. But when I looked at the paper, if you look at the group that they found that had tight FHLs, overall, less than 30% of the subjects in that group had a pathological FHL. So most of them weren't symptomatic. So my theory is if you could do that test again, that study again, with people that had a proven FHL tenosynovitis, I reckon that would change the results completely, just because of what I see in clinic. I'm sure I've got confirmation bias as well, but if you do the FHL knee to wall test with someone who has an FHL tenosynovitis, often there's about a 4 centimeter difference between their knee to wall before and after extending the hallux. And there's an Australian physiotherapist called Stuart Immer, who I first learnt that from.
Yeah.
And he talks about it. And there's no, again, he doesn't mention any evidence behind it. But clinically, he said anything as much as 4 to 6 centimeters difference in that test shows that the FHL is likely causing some kind of loss of dorsiflexion in the ankle. So it's a useful test if you've got a patient who doesn't have full dorsiflexion for some reason. And if anyone who works with feet and ankles, that is the bane of our lives, isn't it? Like getting dorsiflexion. Everyone has lack of dorsiflexion. You're trying to work out why, where's it from, how can I make it better? So if you're not sure if they've got any posterior medial like soreness or anything, think FHL because it could be the FHL tendon limiting that dorsiflexion. And if you do that stretch, it can improve it. So it's a simple way to look at possibly another reason why someone has limited ankle dorsiflexion as well. But yes, I use it clinically all the time. There's not a whole host of evidence
Yeah.
behind it. Mm-hmm.
So just to be clear, you're kneeling, your
Yeah.
foot's against the wall, the knee goes to the wall first.
Yeah, just a
Then you do,
standard wall test. Yeah. Then
then you would
don't,
do this
yeah,
with the
don't,
toe flat.
yeah, with the foot flat. Then tell them not to move and just put either, often use the patient's sock, just roll the sock up and pop it underneath the hallux to get it to about 40 degrees of extension if you can. If it's stiff, you have to go with what you've like 30 degrees. Then retest it in exactly the same position and look at the distance knee to wall. And if it's pathological, it'll be around 3, 4, up to 6 centimeters different. And they'll often report pain in the posterior medial ankle. That's the other key thing.
And then would you take them into that position and just have them like mobilize that area, or what would be your next step there?
Yeah, so I would use it as a stretch for them, but I just
Mm.
wouldn't take them to the point that it gave them any pain. So you'd either lower the big toe, so go to say 20 degrees of extension and then go to full ankle range, or you can reverse it and put the big toe up and do less ankle dorsiflexion. But I would use it as like a graded exposure to that type of
Yeah.
movement. And some of the evidence would show that maybe that could be caused by like a low-lying FHL muscle belly, for
Mm.
example. So I don't think we can change that,
Right.
but without surgery. But I always think with those cases, well, that person's had a low-lying FHL muscle belly their whole life. So it's not just that that's caused them to have the pain or the problem. It's got to be something else. So I would try that. And if it's going to help, it will ease their symptoms and be part of the progression. If it really doesn't work, and then you might get imaging that shows something like a low-lying FHL muscle belly, and maybe that needs a surgical opinion. But because that stretch isn't going to change that, and if anything, it could irritate things if it was a true problem in that tunnel
Mm.
behind the ankle. But I think it's a good first exercise to target. The other thing you can do is mobilize the posterior ankle just with manual mobilization. So talocrural joint tractions and opening out the posterior medial ankle. So if you traction the joint and take the ankle into a little bit of eversion, hold on to that and then pull back. So just mobilizing can help to free up, I suppose, free up the tissue around the back of the ankle. That can help too.
When would you progress to load or not to load?
With
Yeah.
FHL
Yeah.
tendinopathy. So I would always load, if it's an FHL, if it's a really acute FHL tendinopathy, I would offload as much as I needed to get them comfortable ambulating, because that's the thing with feet, isn't it?
Mhm.
People have to walk. So
Right.
I always say to people, we have to be really good at knowing our options to offload them so they can get around and live their life first and foremost. So I would offload them as needed. So that could be as simple as a heel lift, couldn't it? Because we know the heel lift will offload the posterior ankle. You might want to use some kind of orthoses that have an arch support if the foot is very heavily pronating and that's causing that eccentric force through the foot and through the tunnel. So you look at it on a patient by patient basis and address
Mhm.
what they need. But I would offload depending what they needed. So either just a high heel to toe drop trainer, something to get them comfortable. But I would start working as much as possible, even if it was just isometrically in a neutral position, calf, lots of foot intrinsics, and obviously keep them cross training. So if it's a dancer, you keep them on their cardio and Pilates and everything else. So there's loads they can do. And then once their symptoms start to come down a little bit, I start to increase the load, the range of motion, um, I would increase the amount that we're doing the intrinsics. So I'd go from, say, a double leg to a single leg. I'd start to increase a little bit of maybe toe extension with some of that work. We'd start to add in calf raises if they were able to tolerate it. So everything within their tolerance, but just progressing them from two legs to one leg, to increasing range of motion, to increasing intensity, keeping them cross-trained. And then the very last thing that I change is the footwear. So I kind of keep them in that quite offloaded footwear almost the whole journey. And then once they're where they need to be, I'll start to think about the footwear, because we do so many steps in a day
Right.
that actually just I think simple walking can overload the foot, but we're loading outside of that. So, and of course, once you've got your basic strength, measures. So you're back to doing full calf raises. With the intrinsics, the last thing I would bring in would be like for a dancer, for example, would be pointing into a soft Pilates ball. Have you seen those exercises where,
Yeah.
yeah, so in full plantar flexion pointing down. Um, so that's end range plantar flexion, and also things like wall drives. So end range extension and plantar flexion for the foot, but dorsiflexion for the toes. So I'd
Yeah.
bring all that stuff in at the end. And then, of course, you want to think about speed, rate of force development, especially for any kind of athlete. So then I start doing everything faster with intent. And then bring in things like preparations for jumps. So you have to look at landings for FHL, just like you would with the Achilles. That's quite similar. Once you get to
Yeah.
that point, I don't think there's a huge difference. But I would always work the foot just a little bit more with an FHL patient than an Achilles if I had to choose. But I would work the foot in both cases actually, and the same for tibialis posterior too.
Yeah. I think we can agree here too. I think, you know, for some reason, when we look at rehabbing the foot, it's almost like everybody's just, it's a little softer at the foot. There's a lot of bands that show up. And which I always say, you have to start somewhere. I think giving people awareness of their foot is just a huge, at least with the patients that we see. I mean, the dancing population might be, you know, more aware of their bodies and of how their foot is, making a connection with the rest of their bodies. But a lot of our patients, it's like they've never even thought about what their foot is doing or how their foot is interacting with the ground. So starting somewhere. But as far as training the intrinsic muscles of the foot, what are some of the favorite things you like to do outside of, your beginning banded exercises?
Okay, so yeah, so I mean, when if they're in a really flared up state and it's like initial, you're trying to offload, I might try to just activate the foot a bit, and that would be with your sort of toe yoga
Yeah.
type stuff. So I'm still a fan of the piano toes, the foot abduction, the foot adduction, um, and some basic, double weight, double legs. So still weight bearing, but just not on a single leg, and getting people
Mhm.
to, what I particularly like is the forward leaning type work, which loads the forefoot. So even in a very early stage, I would be doing that with someone. So
Mhm.
that's on double leg, and just getting to, I always call it a Michael Jackson lean. I'm sure I'm not the only
Yeah.
person that does that. Yeah. But everyone knows what I mean. Just getting the weight into the forefoot and getting the toes to take the weight and then come back. Those are great because at least their body weight, the foot is working eccentrically how it's designed to work, and you're barefooted. Often when people are doing those exercises, so not for FHL but more for forefoot pathologies, I'll make sure they're on a nice soft surface. so that the metatarsals aren't irritated, or with your sesamoid cases. The surface can be really important, but not so much for FHL. So yeah, leaning forward type work. Then I bring in toe extension. So on a double leg, I'll just roll up a towel or get any of the equipment that you can find, a wedge, toes extended, double leg, lean forward, hold that position. Once they're good with that, then I go to a single leg. So we go single leg, toes extended, lean forward. And the key thing I try to get people to feel is the difference between that horizontal movement and a vertical movement. So to make it harder, I'll get them just to hover the heel off the
Okay.
floor. But quite often they'll feel it in the calf more than the foot. So if you get them to lean forward, just a centimetre is enough. They'll feel it in the forefoot and the foot more, which is that's a nice way to progress it. And then of course you can add load to that, and that goes right up to being in
Mm-hmm.
a squat rack, which I'll do that exercise myself. So that's the most simple toe extension type work. I really love anything barefoot, spread that foot, feel the ground, use the tripod analogy, and then again get the weight forward a bit. If you can get the weight into the forefoot, it helps. And then so any kind of hinge movement, so a single leg airplane, and then pass a weight from side to side, those kinds of movements where you're having to stabilize, but there's load in the foot, you
Mm-hmm.
know, that stuff seems to be very useful. And then foot bridges, love a foot bridge.
Yep.
If it's more midfoot, depends if it's forefoot or midfoot, or if it's tib post. FHL, I'd be thinking more forefoot. Tib post, I'd be thinking more midfoot. But they all work similarly, so it can depend on the person. So yeah, foot bridge type work. Um, and then I go, what else do I do for intrinsics?
Yeah, that forward progression is so important, and it immediately changes the whole dynamic of what they're feeling. I have
Yeah,
so many of my patients that like to, lean back, even when they're hinging or they start to, learn how to hinge. Everything is they kind of get back into the heel. And as soon as they can kind of recognize that forward progression, finding their midfoot and then starting to load the forefoot, it's like their foot just wakes up, which is cool.
yeah. And there's research by, is it Luke Perry, the Australian podiatrist, that he looked
Kelly.
at. Oh,
I
Kelly,
think
that's
Luke
it. Sorry,
Kelly.
Kelly.
Yeah.
Luke Kelly. Luke Perry's an actor, isn't he?
I was, I was like, is he the lead singer of Journey? I know there's a.
Beverly
I
Hills.
also know we listen to the same music. So,
You know what I mean? Luke Kelly, that's it. So he did that work that showed that if you that lean forward loads the forefoot, and yeah, I was just thinking other exercises. So other ones that I like are if you can use tools to help proprioceptively. So again, I love a little bit of toe yoga, but I completely accept that most people can't abduct their toes. It's just a difficult thing to do. But if you can give them something to help visualize it, it can help. So one of the things I like is put the foot on a block and get them to try and open their toe to push it down the side of the block. And then once they get that movement, then add a band to it and then go through range. And then the other thing would be things like, I mean, it's all the plantar fasciitis type
yeah.
exercises that came out 10, 12 years ago. So the toe extended calf raises, I would do toe extended wall drives as well. And then sled pushes, which is effectively what that is. So heavy ankle plantar flexion, toe extension work. So sled pushes and then going up to things like, that's when you're thinking more speed and
Yeah.
plyometrics and landing. But yeah, there's certainly a place for toe yoga and bands at the beginning, but it's getting past that point and adding the load to the foot. Because there was that study, was it this year? It was published by Osborne that showed that the foot and the ankle are chronically underloaded. Yeah.
And it's
And I
wild
like,
because our foot takes on a ton of load. Like we can do some really cool, like you gotta love a good sled push.
yeah, yeah. You can see from the position of the foot, you can see why it addresses the
Yeah.
intrinsic so well, because the foot has to stiffen
Yeah.
in order to transmit that load, and that's what the intrinsics are for. It's to stiffen the forefoot. And we used to think it was all passive. We used to think
Yeah.
the joints locked and the plantar fascia stiffened, but we now know that's not the case. It's the
Yeah.
dynamic stabilizers and the muscles that do that, which I love because it means that we can train it.
Totally.
It changes the way that you think about the foot. It's far more, way more active than we used to
Mhm.
think it was. So
Yeah,
that,
Lauren Welty's research on that was super cool when all that came out. I loved all that stuff. It's like, yes, like we can strengthen this part of our body.
yeah, Yeah. The other thing I find weird is that in that study where they looked at the loading of the foot and the ankle,
Yeah,
calf and ankle was in there, which means we're also underloading the calf. And I didn't
yeah,
think we would do that, but we are. We're not loading it anywhere near heavy enough. I think now the message has been out for long enough that I feel like that's changed. We know the calf can be loaded super duper heavy. We know the loads it can produce, 8 to 12 times body weight when we
yeah,
sprint, and we know we need to load up to 2 times body weight, at high load, low reps to really reproduce the energy that it takes to rehab someone to that
mhm.
level. And that's a lot of the stuff that I talk about when I teach posterior ankle and calf and Achilles.
So important. I
Hmm.
think people have been, at least with my patient population, the education is so important because there's kind of this fear factor when you're like, really? Like we can load it that much? And the resiliency of the foot and how much we can do. And I think that's where the education is so important, which you do an excellent job of.
Yes, I think people just, I think it's because there's nothing to load. Like, like with the
Yeah.
knee, you can move the lower leg,
Yeah.
or with the bicep, you can do a bicep curl. But because the toes are so tiny, it's also why it's so hard to measure, of
Right.
course, right? That's why we haven't got a gold standard foot measure yet in 2025. I think we sort of have actually. I think the force frame by Vald or something similar to that is what I would call gold standard measurement for foot strength. But it's taken us ages. I mean, how long have we had a measurement for grip strength? Years and
Yeah.
years and years.
Yeah.
There's loads of evidence behind grip strength relating to upper limb strength, relating to length of, it's a biomarker for health. Grip strength is.
Yeah.
And I'm sure that once we get better at measuring foot strength and we get a body of evidence behind it, we'll see the similar link between foot strength, big toe strength,
Yeah.
lower limb, ankle strength, and possibly even, like that biomarker for health, like, people with stronger feet will live longer kind
Yeah.
of thing. Yeah.
There was that cool study, I think it was out of Japan, looking at how the difference with grip strength and toe strength, and how actually toe strength was a better, predictor of longevity just because it's more of a physical strength marker than
Mm.
actual grip strength was. And I was like, yes, this is what we need to be doing.
Interesting that was done in Japan, isn't it? Where they're very
Yeah.
barefooted and yeah,
Yeah. Right.
yeah, yeah, yeah. It makes a lot of sense to me. And yes, I think it's the education. We're very good at working every other part of our body, but not so much the feet. But I think even in the last 5 years, that's gotten better.
Yeah.
And social media is so useful to help spread the word. And that's how I learn loads of stuff, just
Yeah.
following people that do this regularly and publish their papers. And
Yeah. I have a question for you. When you have patients with an Achilles rupture,
Mhm.
do you often see an FHL tendinopathy kind of uh, as a secondary diagnosis once they have, worked through their rehab with the Achilles ruptures? I feel like I've been seeing that a lot.
Yeah, definitely. I feel like that's something which is almost it's sort of known about, isn't it? Like
Yeah.
this FHL hypertrophy that
Mhm.
happens because the muscles, the brain, the whole connection just becomes stronger in order to compensate for the lack of the triceps surae. So yes, absolutely. And it's a good example when I teach about the modified calf raise for
Yeah.
FHL tendinopathy. That comes into when I teach and I say, it might be something to consider with an Achilles rupture patient because it technically doesn't allow them to use the toes. And again, we've got some conflicting evidence with just one simple study around that. So I'm not sure whether we need to use that to guide us.
Yeah.
But if you can incorporate that into certain patients' programs, I think it can be really beneficial
Yeah.
because it forces the calf to kind of work. I always talk about the muscles that cross the ankle that help with plantar flexion because there's six if you take the peroneus, longus, and brevis as separate
Yeah.
muscles. So it's not just the calf that does those calf raises. You've
Mm.
got all those other muscles that help. And there's that fascinating study that was done in 1976. Have you seen that one?
Yeah.
Have you seen? So, 19, I think it was 76, where a female had some kind of carcinoma, or there was some tumor or something in the Achilles tendon. So they removed the tendon and the whole of the triceps surae from one side of her body to take the cancer out. And then when she was fully healed, they tested her, they put her prone and they tested her with a dynamometer that was made at the time, her plantar flexion on the uninjured side and the side that had been
Yeah.
operated on. and she could still produce 38% of her full plantar flexion force with no triceps surae.
That's
I
wild, isn't it?
my foot and ankle nerdy brain just loves that study.
I
It's
know.
so
You're gonna
interesting.
have to. I'm gonna need to read that.
Yeah, it's really, you can find it. It's I could
Yeah,
probably send it to you.
yeah,
I've forgotten who it's by. Oh, I can send you the name. But it also is how I explain to physios and practitioners when they come on my courses. It explains why people can still do a calf raise with an
yeah.
Achilles tendon rupture. There's there's still a lot of muscle that crosses the ankle.
So when you're rehabbing an Achilles rupture or an Achilles tendinopathy, would you then do the calf raises with the toes floating so that
Yeah,
they
that's
can't
what I'm saying.
compensate?
Yeah,
Yeah,
definitely. Yeah. I would. I mean, and also it's a nice way to show people how weak their calves are sometimes. So if you do
yeah,
like a single leg calf raise test and then you do it without the toes, sometimes people can't even do one or two. And those are the patients that when they do the calf raise, they claw their toes.
yeah,
The
yep,
people that just rip with dear life.
yep,
And you can tell straight away, if I take the toes out, they're not going to be able to get up and they can't. And it
yeah,
helps them understand why you might be tweaking their exercises. You know,
yeah,
I've had a lot of debates online with people about, do you have to be that specific? Are we overcomplicating it? And I understand what they're saying, but in a lot of cases, no. If you get them to do calf raises, they'll get stronger. Load will go through the entire posterior chain and they'll be fine.
yeah.
But in a lot of cases, they're not because they've done
Right.
that. Yeah. And those are the people that we see, when
Yes.
we're known as having a bit more expertise in the area. So that's when I think having it can matter whether you're that detailed with some patients. I'm not saying all, and I'm not saying that I'm being picky just for the sake of it. But when a patient comes to you and they say, I've done loads of physio, and you say, what have you done? And they
Yeah,
tell you, and then you test them, and you're like, well, it looks like you haven't. I wouldn't say this, but in my head, it looks like you
yeah.
haven't done physio because your feet
Right.
are weak, your calves are weak, you've got no ankle control. So let's start from scratch. And I'm going to show you why you need to do these exercises. And I say this all the time. I know that it probably helps me to get buy-in because people know that I specialize in foot and ankle. So I'm sure it's easier for me to get
Yeah,
patients to do exercises, maybe than other physios. But I I'm quite careful in the way I show them why I think they need to do them because I
yeah,
think it helps them understand why.
totally.
So I just find it fascinating, and you can tell I'm passionate about it, and I think that comes across. But if I say to them, right, look at your big toe, I had someone this week, and I tested them in neutral, big toe against my two fingers, and it went like this. It flickered against my fingers, and it curled and clawed, and literally, it like judded. It was so weak they couldn't produce any force out of it at all. And I said, right, this is a really weak big toe, but that's great because we can rehab that.
Yep.
I love finding weak muscles because we can address that. That's not a
Yes.
problem, you know? So whenever I find someone and they work perfectly, I think, well, what am I going to do with you? It's not as
Yes.
easy. When you get a weak foot, weak calf, poor stability, poor control, lack of dorsiflexion, whatever it is that you can change, I'm like, great, that gives us something to
Yes.
work with.
I
So
always I tell my patients, I'm like, this is room for opportunity. That's exactly
yes.
what this is. And you're definitely speaking my language because I think the detail part of this, like my fiance is a physical therapist, and we
Mhm.
always get in these like, because he's a very big picture guy, and I'm like, but there's a time and a place. So we get in these pretty good conversations because I'm like, there is some detail that has to happen with some of this stuff. And that's what I like get excited about too.
Yeah. And like I say, I have seen sort of criticism when people say you're overcomplicating it for the
Yeah.
sake of it, or it doesn't have to be that difficult, or how does that change management if I'm talking about a differential diagnosis?
Yeah.
And I agree, in a lot of cases, so long as you've ruled out the red flags and you're not missing anything big, a fracture or a stress fracture or a cancer or something big, if you can just generally get them, offload them and build them up, that's what the saying is, isn't it?
Yes.
Break them down or like
Yeah.
whatever the thing is,
Yeah.
break it down and build it back up again. And it does work with lots of patients, which is why we have success as physios.
Yeah.
That's great. And that's how I rehab loads of parts of the body. But when I've got the knowledge I have with the foot and the ankle, sometimes that makes all the difference. And
Yeah.
maybe it's just that I'm trying something a little bit different. I don't know, but I think it matters sometimes. And
Yes.
that's useful to have the knowledge. But it's
Yeah.
not needed for everybody.
Um, I knew this was going to happen. I was like, we're going to get through one question in the hour. I was like, I want to talk to her for hours. The email I sent you, I was like, so this will be 5 hours because I put like three questions on there, which I knew was going to happen. But it's perfect. It's exactly like what I wanted to be talking to you about. You're a wealth of knowledge. So I want to be respectful of time here. Um, Before we end, I do have three kind of questions that we ask everybody, but
Mhm.
I mean, I want to take one of your courses. Where are you teaching? How do we find out about it? Are you only in London? Do you want to come to the US and teach? And what's that look like?
Yeah, well, I've just launched two new dates in London, but they it was wonderful. They both sold out like in a day.
Oh, great. That's so great.
Amazing. Yeah, it was brilliant. So I'm going to do one in November, one in February. They're both sold out, but I've got a waiting list for when I did my next one in London. But I'm going to be teaching in the north of England around the Lake District, probably in March. That will be an open ticketed event. It hasn't gone on sale yet. I'm doing lots of teaching for private events, obviously. I always do that and I'm available to do that. So I teach for the NHS in England and I teach for private physio, practices in England and in Europe. So I'm probably going to go to Slovenia, and I do various different. I'm going to go to Dubai next year as well. Possibly Australia, I think, is on the
Oh, yeah.
card. But I'm thinking about doing an online course, but I need to because I can't just do my in-person course online because everything I would do practically needs to be filmed.
Yes.
That makes sense. So I need to take the time to do that. But I think that would be worthwhile doing because I get people ask me internationally. But I am going to, I was in America earlier this year and I'm going to go back over next year to teach in
Yeah, were you
Florida.
in what, North Dakota or something?
South Dakota, yeah.
South Dakota. Okay.
Yeah, it was amazing. They were lovely. So I spoke at the Sanford Health Sports Medicine Conference, which was good.
That's wonderful.
Yeah,
Um,
so I'm teaching in England again next year.
we'll have to talk. I'd love to. You could definitely sell out a course in the US for sure.
That would be fun.
Yeah.
I'm open to it. I've got a
Yeah.
visa, so I can do it.
There you go.
I went through hell to get a visa, so I can. I've
Yeah, I bet.
got a visa for 10 years, so it's easy.
Slovenia is wonderful too. That's one of my favorite places. It was like a little like I didn't realize how beautiful and wonderful that country was.
I haven't been, so that's great. I'll look forward to doing that. Yeah.
Yes, it's great.
Are you coming to England anytime?
I might be there in September.
Okay.
So yes, I'll let you know. We'll
Yeah.
chat about all that.
Yeah.
Okay, last three questions. Um, for the audience, if there's one bit of advice that you could give to clinicians, what would it be?
Oh no, these are hard. I hate these questions. You didn't give me any warning, so I haven't had a chance to think. One bit of advice for clinicians,
Yes.
what would it be? Do you know what it would? In a way, I'm going to be a bit selfish and talk about us as clinicians rather than the patients we treat, because I, as a clinician, often struggle with imposter syndrome, with the constant worry about whether I'm doing the right thing, whether people, you know, think what I do is good, whether I've gotten someone better, did they get worse? All of those terrible worries that you get as a clinician. I struggle with that all the time, and I know I'm not the only one because I talk to lots of people about it. Yeah. And I don't know, I hope that it's a good thing because it kind of keeps you humble, makes you stay, it makes you, I don't ever think I know it all. Far, far, far from it. It's much more, the more I know, the more I know, the more I realize I don't know.
Yes.
Um, but then when I think back to say even 3 years ago, and I think, God, wow, I've learned so much in 3 years. And then I think, well, how was I working 3 years ago when I didn't have this level of knowledge? And it's just that ever evolving
Yeah.
thing that you have as a healthcare professional, which is both amazing, but also very challenging.
Yeah.
You never know everything. You never feel like you know it all. I certainly don't. And I don't think we should because we don't as a profession anyway. So I suppose the advice would be just to know that if you feel like that, you're not the only one. And it's probably a good thing because it's going to make sure that you stay within your scope of practice, that you discuss cases, and that you'll always do your best for people, I suppose. Yeah.
I think I love that so much. how I feel 100%. And I think people, clinicians love hearing that, there's not a clinician that I, have had these conversations with who don't feel that way. And I think it makes you like, read more and study more and surround yourself with people to have these discussions, which is why I'm so grateful for these conversations because I just learned so much. So thank you for that. I appreciate that. Okay, next question. Any
Uh-huh.
book? What's your favorite book? Fiction,
Oh,
nonfiction?
I know. So fiction, it would be Memoirs of a Geisha. You know that story? I
Yes,
love that. I love that story. I just think it's so beautiful. I love where it's set.
love that book.
Japan, I just love it. And my favorite non-fiction book is Christopher Reeve's autobiography, which is called Still Me. And it's because it's quite medical, because he talks about his spinal injury in it. And I found that really fascinating. But I just found his injury so tragic and, oh,
Yeah,
fascinating in such a terrible way. It's such a tragic story. But I love reading people's biographies, and I particularly enjoyed that one.
yeah, I have not read that. I'm going to.
Yeah, just from a medical perspective, it's
Yeah.
interesting. Mhm.
Last one. Um, if you could listen to one album, one music, you're driving in the car and you want to put some music on, what are we going with?
Does it have to be an album by one artist?
No.
Okay, so, oh, it's hard, but I'm going to go. I love that you didn't tell me these questions because it's going to be very spontaneous.
Yes.
Um, it would be some kind of 90s R&B playlist.
Love it.
So it would have like your Michael Jacksons and your Janet Jacksons, but it would also have now I can't think of all the people in it, like Mariah Carey and just any 90s music, but definitely with an R&B twist. I would otherwise I'd have said something by Michael Jackson. I love his like Bad album, but I'd go
Yes.
more general 90s R&B. The other little tip for you, anyone who's listening that works with dancers, if ever you work in a theatre, it doesn't matter whether it's now like with brand new dancers who are now 20, if you play them 90s R&B, they will love you.
It's a great tip.
Yeah.
My cousin, who I'm actually staying at her house right now, is a massive Michael Jackson fan. So there's like Michael Jackson stuff everywhere, and we're a big Michael Jackson family over here. It's pretty funny.
Yeah, they just because I used to do the warm up at Lion King. So
Yeah,
once a week, I would stand on the front of the stage and they would follow me. And I just played 90s R&B and they loved it. And I used to
so
play it
fun.
in the treatment room too. So I'd be playing, say, and Whitney would come on. And of course, remember in Lion King, you've got all these divas that can sing, and they'd be singing Whitney to me
Yeah,
in the room while I was
it's
treating
awesome.
them for their ankle. So I deliberately played them Whitney Houston and got them to sing for me. It was very selfish. But there you
Well,
go.
if you come to the US, we can take a road trip and listen to 90s R&B along the way.
Amazing. Did you see I did a road trip in South Dakota? We went to Mount Rushmore.
Yeah,
Yeah.
that's what I was thinking about that. I'm like, that would be very fun.
Yeah, yeah.
I've never actually been there, and it's like, of course, it's like a bucket list place. It's always wild when, you go to different countries and you're like, wow, they've seen more of the country than I actually have been. So
Yeah.
that's
It's
a
worth
spot on my
going.
list.
It's worth going. It's really special.
Well, thank you so much. This was so great. We all appreciate your time. You do some wonderful, wonderful work, and I cannot wait to take one of your courses. I'm going to. I think you should do an online course. I think that would be great. It is a lot of work. Um, but yeah, it would be a huge success. So thank you again.
Thank you. Thank you for having me. And same back to you. You do amazing work and I follow you and loads of my patients follow you because they say, "Oh, I got this from Gait Happens."
All world.